Okay, welcome back. Thanks to all of you for your energetic contributions to the breakouts. We're now going to have a little bit of time to hear from each of the groups about what came out of their breakout sessions, and then to have a little bit of discussion about those ideas, and to really have a bit of a discussion about how one could take action around these ideas and who would need to be involved and who would need to be convinced. So we will do that. Then we have a final panel that's really going to help us think about the future, and then we're going to have some time to get some of the key takeaways from both our planning committee members and the audience. And that takes us through to the adjournment of our workshop. So I think Andre is going to report back from one group and Oscar from the other. Is that right? Right. Great. Shall we start with this group? Oscar? And I'm going to ask you, from wherever you would like, as long as you use a mic. Hold that.
I'll hold it.
Button it on your.
Thank you.
Lavalier.
First of all, I want to thank Margot and Josh for putting up with all of us. And for putting this up on the board. My name is Oscar Morgan. I'm with the Central East Mental Health Technology Transfer Center, which is under the Danya Institute. And we had a very lively and robust discussion, and we finally realized that our work could be made easy if we just recognized that Mike Hogan and David Covington have told us everything we need to know. And we just have to, use that as our guiding light. So we were the team that was looking at the clinical side of the house, and we realized through our deliberations that a lot of this has already been codified in the book, Crisis Now. So our recommendation is that the National Academy would suggest to SAMHSA that they send a letter to each governor quantifying the crisis from a national point of view, and then specifically talk about that state's issues from a data point of view, and suggest to the governor that he or she would implement the recommendations of the Crisis Now book. And then that SAMHSA would also inform the governors that through the various SAMHSA's technical assistance centers, that they could get free technical assistance on how to implement this. And that the technical assistance centers would work together around a uniform, with SAMHSA, and by default, Mike and David, on a uniform implementation strategy. In terms of what the training would look like, realizing that states may be at different levels, but through the training, certain elements would be covered that would help to lead to a implementation of the book and essentially zero suicide, with the focus being on persons with serious and persistent mental illnesses. So that's what we came up with.
So we're going to hear from Andre next, and then we'll have some time to discuss.
Great, thank you very much. So our group was tasked with looking at financing and policy aspects of people with severe mental illness that are at risk for suicide. And we called an audible and took a different tactic. We were planning to do some prototyping, and we felt like it was more appropriate to get some clarity around for whom are we designing, what problems exactly are we trying to solve within those realms. And so we, instead of taking a prototyping approach, we did a brainstorming kind of a group and cluster approach. And the specific task we started with was coming up with a user story. So an end user needs a better way to do blank so that they can blank. And we started off, there was a trend that someone observed saying, many of the user stories were, a clinician needs a better way to do X. A clinician needs a better way to do Y. Clinician, 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 but what are we here for? Are we here for clinicians, or are we here for the consumer, the patient, the client? And so we did a little bit of reframing, and just to highlight some of the aspects. So we were thinking about user stories looking at liability concerns for the clinician. We were looking at user stories around clinicians not having consistent access to evidence-based practice in preventing suicide for folks with SMI. There are other user stories looking at making sure there's adequate access just to trained providers and having health systems provide enough financial incentives for providers to come and work there. We decided to narrow our scope, however, and try to focus on a user story that we could, within a 45-minute period, really chew on and come up with a concrete output. And there was a theme around transitions. In particular, there was yesterday a lot of discussion and evidence around at what point are folks with SMI at the highest risk for suicide, and one of those points is when they're transitioning. And in particular, the transition from the emergency room once they're identified or at risk for suicide, and also from a psychiatric hospital out to the community. And we thought that was a much more digestible problem to try to wrap our heads around. So we codified it more explicitly to say a health system needs incentives to focus resources for people at risk for suicide who have SMI during the time that they're transitioning from the ER to the community or from a psychiatric hospital to the community. And so how do we address that issue? How do we solve for that problem? And we got into identifying, well, there's measurement challenges and aligning measurement with financing. There's challenges in terms of just the complexity and breadth of what a good transition would need to look like, including, this isn't just a medical model, but looking at all the community resources, the family resources, all the different care team members that would have to be involved and adequately financed in order to provide a good transition. And also there's issues around geography and access, rural access to transitions. And we were brainstorming around what some solutions might look like, and there was a nugget that really, it's got some eyebrows to pop up, and there were some words like wonderful, and there's some momentum brewing around bundled payments. And so could there be a bundled payment for transitioning people with severe mental illness at risk for suicide from the ER or from a psych hospital out to the community? There's already precedent there. There's bundled payments that have happened in many other settings, not just for public payer funded mechanisms, but also with group or commercial insurance. So there's some analogs to build off of there. And so we started getting into the weeds a little bit around, well, what would a good bundled payment mechanism look like to incentivize a good transition? And we got into some of those nuances. I won't go into all of them, but it's important to think of things like having appropriate assessment for someone who's at risk for suicide, establishing a safety plan, making sure that there are adequate number of actual contact points when someone is transitioning from the acute care setting out to the community, making sure that the family is engaged when they're there, as well as making sure that the receiving, so to speak, providers out in the community are part of the financial incentive, not just the entity, the acute care entity that's sending someone out. A couple of other ideas that were brought up that we did not fully digest, but certainly worth exploring. What about not just a financial incentive in the acute care setting transitioning to the community, but upstream of that? What if someone is identified for at risk for suicide in a primary care setting, or if they're calling an emergency hotline? Are there financial models that could be employed there? Also, problem that's my organization certainly suffers from as well is there isn't enough of a financial incentive for EHR adoption in the behavioral healthcare space. And so how can we do adequate transitions if we don't have electronic medical records universally adopted, or electronic medical records that are competent? And we got into some nuances of actual dollars and cents. And so I think an interesting potential takeaway, especially we have some CMS colleagues in the room, is there's already precedent for bundled payment. It's not starting from complete scratch. It's a matter of focusing on this particular patient population, folks with severe mental illness at risk for suicide, and making sure that the financial incentives are aligned with evidence-based practice in transitioning folks out to the community. Did I miss any major themes from folks that were in the group? Awesome. Thanks.
So we have some time for discussion of these ideas, other ideas that come to you, questions back and forth between the groups. I do ask that for the sake of our webcast audience and our video archive, that if you do have a question or a comment, that you go to one of the mics, even though I know that feels a bit formal in this room, or I can hand you this mic if you prefer. To kick us off, I know there was kind of a next question percolating out of the second group, so I'm going to ask that question to the room. This first group, talked about influencing governors to rally the resources to then kind of change the practice of providers to bring together what they need to in their state. This group didn't get as far as that question, but I know I heard multiple conversations about taking this idea specifically of this bundled payment for these transition needs for patients with serious mental illness who have been identified as at risk of suicide. Who would you need to influence or convince to get this idea into action? I know we did just call out our CMS colleagues in the room, but who is it that you would want that idea to be in front of? Who really has kind of the power to make that change? Yes, here.
Hi, guys. Andre again. I'm obviously a little biased, having come from Medicaid in many aspects of my professional and personal career. Given that there is already an immense amount of flexibility in how the Medicaid statute and funding authority can be used, this is perfect grounds for an 1115 demonstration. The constraint is it would be on a it would be on a state-by-state basis. And so that could be one route. I think also, CMMI having a new model that could be more comprehensive than just Medicaid could be really interesting. And finally, as long as the financial argument could be made, and I think probably it could be made either directly by total cost of care savings or from a increasing market share perspective, commercial group insurance. If this template, if you will, could be proposed to them, and you get a progressive group or employer-based insurer to take this up, we don't have to wait for a model to be designed by CMMI or through the long process of getting an 1115 demonstration approved. You just get a health plan that's really progressive, wants to save money and or improve outcomes. And I'm not prioritizing in that order from my personal view, but just the financial realities. I think this could be done in pretty quick time.
Nadine?
I also think that we need to collect more data about this before, these are not, maybe these can go in parallel, but a lot of the things we talked about was applying things that we know from a context that may or may not all be applicable to serious mental illness. And so I really think that we need to look at the things we talked about, see how effective they are, and see what pieces need to be modified, what may be missing, what may need to be added or taken away. So I think we can fund these concepts and go argue for funding, but I also think we need a lot more data collected. So I know we have other kind of funders in the room besides people who fund healthcare policies, and I think we need to think about that too.
So just a couple other random thoughts about this. We do have this big thing going on with respect to serious mental illness, which is this ISMIC, Serious Mental Illness Coordinating Committee, which is right in the middle of this kind of stuff and may have enough openness or bandwidth left to consider this as an issue. And since that is an interagency committee that includes but extends beyond SAMHSA, that might be useful. So just a thought about that, and then just to come over to the other one for just a second, as long as I'm here, and this is good with Richard having stepped out of the room. I mean, because sort of asking SAMHSA to do something with governors is a little sensitive, and it might not be possible to get from here to there. And so ironically, the argument might be strengthened a little bit by having the National Academy do something that then would be kind of sort of more neutral, that then could be,
I have, sorry, please, go ahead.
Just to build off of that, so the ISMIC was created in 21st Century Cures, and 21st Century Cures also created the National Mental Health Policy Lab, which again is designed to drive policy changes, so it might be another option for that.
Hey, Sherry Ling, thank you for the constructs and the work and the thought-provoking concepts. I think, this is also about identifying where those bright spots are that you could say it's working, whatever it is, because no doubt, integrated care, whether it's integrated over settings or space, there are tremendous opportunities to drive to that. But in addition, still at the front line, it's what should be done, by whom, when, and tools and evidence at the point of care are really important. So no doubt there might be people who already have figured this out that can be a starting point, sharing best practices and the like. So I don't disagree that more evidence is needed, but I would also say that, where we can learn from what is working is an important starting place.
Go ahead, Richard.
Yeah, so a couple of things. So one would be, in terms of this notion of a bundled payment and also the debt, I think the evidence is really solid behind the things that need to be done during the transition period. I think the things that we don't know yet is exactly how that translates from the populations that all the studies have been, which I find very persuasive, have been done on, and specifically to people with schizophrenia, bipolar disorder, et cetera. That's a piece that we don't know as much about, which would certainly be useful too. But I think it would be, if there was a way of moving this forward, if there could be a bundled payment, I think that it would be so useful and important to have that. And we obviously would want to learn as we went forward. I think the other thing that came up in our discussion is also the possibility of different needs, and may also have to do with cost effectiveness as well, because there's a substantial literature that's talked about using telephones, that's talked about using text. That was a study in the military recently. During the transition period, really low cost interventions. I think the question would be, at least for some part of the subgroup with SMI, is that less feasible because of the absence of the technology? And is there more of a need for face-to-face contact? Now, VA has been doing, like home visit work, and that's presuming even that you have a home there. So there are some important issues to tackle kind of in parallel, with trying to move, something forward. But also, I think one of the things I've been wrestling with is kind of the nexus of responsibility in terms of CMS and states. Because usually when I talk to colleagues at CMS, one of the things that they emphasize, at least in terms of Medicaid funding, is how much it's a state issue. I mean, that it's relatively rare, I believe, and anyone here from CMS, they're correct, but it's relatively rare, I think, for CMS to just say, this is what Medicaid in states is going to do. But I think it's one of those things where clearer guidance for states to utilize about how to do things would be important. For example, that it's really critically important for the mental health commissioner to have a relationship with the Medicaid commissioner. That it should be in the state Medicaid plan. Those kinds of things that the average person working in suicide prevention is not necessarily going to be aware of. Mm-hmm. Yeah.
We picked Maryland Republican governor as We picked the governor as the key holder in the state to really make a decision on this. Do you agree that that's the right person that we should be interfacing with at that level? Is it, or should we go way more?
Well, I think it's clear that getting the governor on board is the best possible thing within the state. Now, in terms of, I'm not aware of any time that SAMHSA's ever sent a letter to all governors. There have been a couple of Dear Medicaid directors that have gone out jointly from SAMHSA and CMS. I know that that's been done. How feasible that is, I mean, it's obviously an idea that could be, that could be floated. The other thing, what's the appropriate level for communication to a governor? Should that really be, for example, the Secretary of Health and Human Services doing something like that? But, this is, but somehow engaging the nation's governors, I think obviously would be critically important.
In my presentation yesterday, I mentioned some of the state laws that have passed over the last decade. And one thing that AFSP has been building is a mechanism for all states to have a state suicide prevention day, where all of the asks and the evidence can be presented at the state level. So this would certainly be something that we would love to participate in if we can package it up.
A thread that I heard building through yesterday, and then I think applies to both of these solutions that I'm going to raise as something for discussion. Both of these ultimately converge on kind of changing the knowledge, attitudes, and practices of care providers, ultimately, although through different pathways. And financing for them is certainly one major way to change what they do. We also heard a lot yesterday about worries about liability, fear, not knowing what to do, and that applied to people who are trained to work with serious mental illness, but who may not have the knowledge and practice skills to address suicidality. And then some of the cohorts of workers that are doing a lot of face-to-face work around suicide prevention, community-based work, provider-based work, who may be having increasing access to evidence-based tools around suicide prevention, but don't have skills around how to do that work specifically with this population of people with serious mental illness. So it seems like there's almost like a culture of practice or getting a discomfort in both of those spaces, just among the real practitioner level. So I'm wondering if people have any thoughts about, is there something beyond making sure that that work can be paid for and that the trainings are available? Those seem like two really important pieces of the puzzle. But is there anything else that professional organizations, who else should be engaged in order to really change what happens in these professional practice communities for these different cohorts of workers?
I did that before I got to the mic. I think my bottom line on this is if you pay for it, they will come. It'll absolutely get figured out. And that's partly, I think, true, but partly also the solution to this problem that goes through either pre-service or continuing education credentialing is like invading Russia in winter, because it involves licensing boards or professional associations, higher education places, all of whom, with no offense to the smart people who are in that space, most of the people doing that work were trained 20 years ago in something else. So anyway, all that stuff will change if this gets paid for.
I see Jim getting up, so.
I was just going to suggest that I think all these things are very true, and that it's a very wise question to ask, because everything we know from implementation science has caused us to really think carefully about how do you create professional buy-in, and that's crucial to actually implementing a system of care or implementing a change to a system of care. So that's a nice example of why things don't get implemented, that last discussion about just how do we make continuing education work. So I think a very thoughtful rollout that involves local decision making. There are many models of how you respond to an actively suicidal individual. They all have an evidence base. The important issue is that the provider, community, and estate pick one so everyone shares the same pathway and shares the same vocabulary. And they will do that if they feel they were part of the decision process at arriving in that. I think that's very critical. And the other critical thing, I think, is involving consumers in that decision as well, and their agency too.
Hi, this is Amy. I'm from the Education Development Center. And there's a piece in here, from my perspective, that is about where does this stuff live? And we have many different organizations, professional associations, advocacy organizations, but it seems like this population and this issue is a specific subset of psychology, social work, what have you. And I wonder if perhaps there's a need for an organization or for formalized collaboration to just focus on SMI, suicidality, and the people who provide services to that population, because it's a very specific subset of all of these different professions. And I just wonder, are we so parsed out that we're not, harnessing our resources in a way that will allow us to move forward?
I just want to butt up against that statement as well, too. In our group, one of the underlying themes that really came up was the idea of codification across treatment, across just broader understanding. I didn't know this, but because I'm not from this world, but that's part of it, I think. There are 10 modalities to help treat suicide, and a lot of them are evidence-based, a lot of them are similar. And so how do we kind of unify and create one standard definition across all these belief systems, if you will, or across the treatment of this issue? And that might actually help fix the financing streams that we're talking about too, and ultimately improve care for everyone.
Yes.
I'm Julie Goldstein-Grummett with the Education Development Center. I wasn't here yesterday or this morning, so it's quite possible this was already discussed, or I'm in the wrong room. But one of the things that occurs to me is that, from where I sit, I see a lot of wonderful best practices and great outcomes beginning to occur on the local level, but people have a very hard time publishing those results and sharing those practices. And so I feel often like there's great attempts at corralling how to use these evidence-based practices for great outcomes, but we don't see it. And so it remains very hidden and very siloed. And so I think one additional potential opportunity would be journals really reaching out, specializing, offering these kind of intersections about people with serious mental illness and suicide, or opioid abuse and suicide, but also cultivating the authors who aren't typically submitting, right? We have many state suicide prevention coordinators, tribal elders and leaders, people in rural areas who really are being, heroic in finding ways to combat suicides in their community and have outcomes, but have a hard time getting it onto a national stage.
There was a little bit of, just to tie in a theme, yesterday discussion about how in some cases research actively excludes people with serious mental illness. So that means the evidence base and the knowledge base is always having to be applied in a way that you're assuming transferability to this population, but you don't actually know, because for reasons of study design and interpretability, these most complicated needs aren't addressed in some of the literature that's out there. So the topic of additional kind of authors and who the authors are and how they have access didn't come up, so that's a nice add-on.
So this is kind of related, and it links to the first group's invoking this new SAMHSA TA thing that has just been launched with a national dissemination center and then HHS region-specific centers. And I'm sure the people involved in that know exactly what that's for, but nobody else does yet. And so I think this is to some extent moving away from an old model of TA that the assistant secretary is not endeared with for, I think, some very good reasons, and a new model of TA that would be more focused on evidence-based practices and so on. And so it occurs to me in this context that the evidence base for working with individuals with very high suicidality is, it seems to me, now, just within the last couple of years, unequivocally established. Although there might be people who would want more RCTs and stuff like that, but they're in a dark place if they want that. The evidence is pretty clear, but it's also new, and as Julie points out, it hasn't been synthesized. One of the things that has not been done is, do we have an RCT evidence for zero suicide? Well, you can't do that because the numbers involved would have to be in the gazillions, because it's such a low base rate event. What we have is that people who are doing it have achieved bigger reductions in suicide than anything else in the world. And we have the fact that it's made up of components, all of which have an evidence base. Anyway, after that tirade, so my point is just that there's an opportunity with this new TA structure to get this stuff in on the ground floor when the mission is just emerging for that TA structure, and that could be really helpful because the field is at such the real world field is at an early adoption stage when targeted information could be very helpful.
As the only anthropologist in the room, I feel it's my duty to complicate things for us. You're welcome. You're welcome. I want to agree with what Dr. Hogan said, but I also want to add a little cautionary note that we need to remember that we are a very diverse peoples, and that not one size does not fit all. So that while we may have a very strong evidence base in the populations in which the research was conducted, we need to be very thoughtful about who was included and how it was evaluated for the diverse populations that make up our United States. So I would put a plug in for additional research for validating those practices in the communities that are so often described as minorities, although they are less and less so. And I also would put in a plug for more work like what Jim and Dr. Rasmus and Dr. Wexler are doing in Northern Alaska for developing an evidence base for culturally grounded and culturally driven evidence-based practices. We need to support the evidence that already exists, or at least document it, so that we do not have a myopic view about exactly what constitutes evidence and what constitutes best practices.
Great. Well, we're going to transition now into our final panel. And this panel has been charged to really think about what could be. And we have perspectives along the continuum all the way from, really the direct patient experience of systems of care and outreach directly working with patients and clients, all the way up to behavioral health systems at state and city levels. So Nadine from the Planning Committee is going to moderate this panel, and I'll invite Julie and Arthur to come up to the table, and our third panelist is going to be participating remotely. So if everyone has just a little bit of patience while we make sure that we have him all set up and ready to go. Thank you.